cause difficulty achieving pregnancy as well as complications during pregnancy. There are a few aspects of fibroid surgery to consider. First is what type of surgery to choose while taking into account the pros and cons of each. Surgery can be a myomectomy, where fibroids are removed without having to remove the uterus, and hysterectomy, where the uterus with all its fibroids is removed. Another aspect to consider is the route of surgery, which can include minimally invasive surgery such as laparoscopic or robotic surgery versus an open procedure. A few factors can help guide a joint decision with the patient whether to proceed with myomectomy or hysterectomy. This can include the patient's age, desire for future fertility, the number and size of fibroids, as well as considering the risks associated with each surgery, including the risk of recurrence. Some factors can be associated with a higher risk of fibroid recurrence. This can include the patient's age, higher overall fibroid burden, including increased number and size of fibroids. Fibroids can behave differently from person to person. Even within the same person, different fibroids can behave differently. Symptoms that can suggest recurrence of fibroids can include worsening menstrual symptoms, such as worsening pain and increased flow. Additionally, patients can report worsening bulk symptoms, including pelvic pressure, urinary symptoms such as urgency, and back pain. Fibroids could cause difficulty achieving pregnancy as well as complications during pregnancy. The important thing is to discuss those risks and formulate a plan while considering all available options, including medical and surgical treatments of fibroids as well as fertility treatment if necessary.
The reason why I'm focusing on adolescent endometriosis, and this was a fantastic article, it's actually by one of the authors, Dr. Einerson and Dr. Lee. It's about evaluation and management of endometriosis in the adolescent. The prevalence and diagnostic delay. The symptoms of endometriosis typically begin in adolescence. In one registry survey, 2/3 of adults with endometriosis reported that their first pelvic symptoms started before age 20 years, and 21% had pain before age 15 years. In certain cases, adolescents may exhibit atypical presentations of endometriosis and might not undergo laparoscopy, leading to potential underdiagnosis and making it difficult to ascertain the actual prevalence of the disease. Listen to this. Nevertheless, among adolescents seeking medical evaluation, the prevalence of endometriosis appears to be notably high. A systemic review, which means a review of looking at everything, all articles. This identified the overall prevalence of laparoscopically confirmed endometriosis as 62% adolescents undergoing diagnostic laparoscopy for any pain, 75% in adolescents with chronic pelvic pain resistant to treatment, which means they were put on birth control or some type of hormonal medication, and 70% in adolescents with dysmenorrhea. Despite the high prevalence, many adolescents with endometriosis experience diagnostic delay. Adolescents frequently see multiple physicians before receiving a diagnosis of endometriosis, and the younger age at onset of symptoms has been associated with a longer diagnostic delay. Diagnostic delay in adolescence appear to be both patient and clinician mediated.